Hello, good morning from the Philippines. This is Aliyah from the Asia eHealth Information Network. Welcome to our special AHIN Hour, part of our bi-monthly webinar series where we feature topics on eHealth on a special schedule. This webinar is attended by 25 countries in South and Southeast Asia, mostly members of the AHIN. If you're not yet a member of the network, we'd love to have you, and please join us at www.ahin.org. Our topic for today is about the Primary Care Information Project entitled Leveraging Public Health Data from a Network of Outpatient EHRs, the New York City Experience. In 2011, PCIP established the Hub Population Health System, a query tool which can gather aggregate count data from 700 plus participant outpatient practices. Using the Hub, PCIP has monitored changes in HIV testing, high-risk medication prescription, hepatitis, C testings, and many other content areas. This presentation will provide an overview of the organization of PCIP and explore the ways in which EHR data is being leveraged for population health in New York City. We'd like to thank Melissa Chu for helping us organize this event with the New York City Health Department. Some things to remember before we start our session: our platform, how to participate, our program, and the email feedback. First off, we're using the Cisco WebEx Event Center, and if you are encountering problems as you participate, please log out the session and rejoin the meeting room immediately. Our meeting room number is 830-649-839, and our password is New York 123. Your mic will be mute for the rest of our meeting, but you can actively participate by sending your feedback to the session, chatting your response, and posting your questions. Send your feedback to us by clicking the dialog box with a check mark which says yes or no, too fast or too slow, applause, and laughter. Let's try to get feedback in this room. Can you answer my question? Are you feeling well today? Please hit the dialog box with a check mark so that I could see the responses of our participants in this meeting room. Did you find the dialog box with a check mark? The dialog icon with a check mark. Thanks, Nina, for raising your hand. How about the others? Thanks, Win, for the check. We'll wait for the others for their responses. Thank you. You can chat your response by typing your message to the speaker or to the panelist, the host, or both in the meeting room. But I have a warning that you cannot chat your response to all attendees in this meeting room because WebEx only allows chat to all panelists for participants to facilitate order in the meeting room. You can post your questions by firstly assigning the question and typing your question in the Q&A box located on the right panel of your screen. For our program details, the session will run for 45 minutes to 1 hour, and you can send your questions to the Q&A box as it arises from your head. And lastly, please do not forget to check your email to answer the very short evaluation which will be sent to you directly by our platform. So those are the things we have to remember. The Cisco WebEx Meeting Center, our ways to participate, our program details, and our email feedback. This morning, our speaker, Remla Newton Dame, is a Senior Manager of Population Health at the New York City Department of Health and Mental Hygiene in the Primary Care Information Project. Ms. Newton-Dame works with electronic medical record data to understand population health and trends. She's particularly interested in how EHRs are being used for chronic disease surveillance in the U.S. and abroad. Ms. Newton-Dame is pursuing her doctorate at Johns Hopkins Bloomberg School of Public Health, where she focuses on obesity. Please welcome our speaker on the topic leveraging public health data from a network of outpatient EHRs, the New York City Experience. Hello, Remla. It's nice to have you very early in the morning.
Late at night for me. Can everybody hear me okay?
Yes, we can hear you well. I see some of the check marks.
Fantastic.
You can now share your screen.
Great. Can everyone see my slides?
Not yet at the moment, but I think it's arriving from our end. Click on the Quick Start tab and share your screen. Okay, I think we're on it. Thank you.
Great. And I'm actually going to ask you as host to interrupt me with any questions that appear in the question box, as I won't be monitoring it during the slides, but I do want to answer things as they come up. And then we'll have plenty of time for questions at the end.
All right.
So hello. Good morning. My name is Remley Newton-Dame. As mentioned, I work in population health monitoring at the Primary Care Information Project, in the New York City Department of Health and Mental Hygiene. It's a lot of acronyms. And today, I'm going to be talking about how we've leveraged public health data that we have access to here in New York City through a network of outpatient electronic health records. Please definitely keep note of questions. I'm happy to answer any and all questions that I can, or put you in touch with someone who can give you a better answer if I can't. So today on the agenda, I want to tell you a little bit about the Primary Care Information Project, about how we leverage EHR data for public health, and then highlight some of the kind of overview and high-level results that we've received. So in the United States, we've had really an explosion in the use of electronic health records, albeit a slow-moving explosion. So in 2001, only 18% of office-based physicians used any form of an EHR system. In 2012, that had risen to 71.8%. Aaliyah, is everybody having trouble hearing me, or just one person?
Let me check on that. I think we can hear you very well. I will just ask the person to adjust.
Great. So within that 71%, it's actually increased since then, and only about, of the 71%, about 50%, so 20 percentage points of people have an EHR system, but it's not a good EHR system. It's not a comprehensive EHR system. So 50% have a good EHR system, but that's still considerably more than we had a decade ago, and it shows great promise. And the reason that it shows great promise is that EHRs transform medical records into actionable information. And if you are participating in a call on the eHealth network, this is not going to come as a shock to you, but it has the potential to really transform public health practice. So we can take these medical records that previously were trapped on the shelf, we can turn them into research, we can turn them into feedback, we can turn them into trends, and we can turn them into geographically targeted information that can help us inform our program planning. So how do we get actionable information in New York City? We get it through the Primary Care Information Project, or PCIP. We are a bureau of the New York City Department of Health, and we were founded by Mayor Bloomberg in 2005. We're one of his many legacies in the public health arena. Our mission is to improve the quality of care in medically underserved areas through health information technology. And we've done that a lot of different ways. We really help folks to improve the quality of care that they're delivering with the electronic tools that they're using. We help them to achieve a lot of program statuses that we have here in the U.S., and we help them to achieve something we call meaningful use, which I'll mention a little bit more later. So we have now worked with about 15,000 providers to adopt an electronic health record and to achieve this meaningful use status, which is where the federal government will pay a provider to show that they are utilizing the electronic health record, originally just using it, and then that they are actually achieving quality thresholds on the electronic health record. This translates to about 1,200 small and medium-sized practices, 81 community health centers, and 30 hospitals and hospital-affiliated outpatient clinics. So we have a real breadth of the kind of practices that we're working with. All of those practices are in New York City. So we here at PCIP really use EHR data to ground the quality improvement that we do. So we see using the IOM framework of 3 core public health functions, data, policy and dissemination, and quality improvement, are our versions of assessment, policy development, and assurance. So in assessment, we really make sure that everybody has adopted an EHR and has the ability to share data. In policy development, we do research and evaluation. We target our programs in the way that we think is going to have the most impact, and we actually build community partnerships. And then insurance, we make sure that the quality improvement that we do is actually hitting home and having an impact. We do data analysis to support our providers and to give data back to them. We do technical assistance. We offer them assistance with their platform and with their quality of care. We help them achieve that meaningful use criteria, so actually getting reimbursed for the massive investment that they've made in health IT, and we actually give the data back to the providers to empower them. So we also do kind of 4 broad buckets of activities. The first is really getting people onto the electronic health record. So making sure that a doctor who's interested in being on an electronic health record can get there. Once somebody's on an electronic health record, we want to help them take it to the next level. And so that's going to translate to quality improvement work. We are looking at and investigating a lot of new reimbursement models like pay for performance and pay for quality, where providers are actually rewarded for surpassing quality network thresholds. We do patient engagement work and help them understand how to be able to generate letters, for example, to their patients so that there's better feedback. We actually engage in community projects and help them connect to community resources, and we help them become patient-centered medical homes. The next step, once they've achieved more quality, is achieving that data sharing. And so we put that as the interoperability area. In New York and in the United States, we are currently in the process of forming what's called health information exchanges. I'm not sure what the terminologies are in other places, but lots of places have kind of ideas around this, which is that there'd be a central organization that functions as a catcher's mitt for all the data of different practices. And when you have a patient come in, you can query a centralized database and pull their data down from wherever. In some places in the U.S., this is a reality. In New York, it's really still getting developed. And so that's a big goal for us, is to foster these health information exchanges. Also, we need to have functional interfaces from these EHRs so that when a lab comes back to a practice, it can come directly into the electronic health record rather than coming back via paper or PDF. And then finally, in the U.S., there's reimbursement reform around what's called accountable care organizations, where groups of doctors band together to receive joint savings in any reductions they can do in cost and in morbidity among the patients. So that requires a lot of data sharing, and we want to make sure that that is really possible for our practices, because we think that's where public health is going to move forward in leaps and bounds. And then the last bucket is the bucket that I work in. That's public health monitoring, and that's mostly what we're going to talk about today. And so within that, we have a diabetes registry that was mandated by Health. We engage in federal initiatives like Query Health. We do disease surveillance and management, and we have ways of getting data. So today I'm really going to talk about one specific way of getting data, but we have lots of different data streams here at the Department of Health, and we actually blend all of these data streams to create a more rich data perspective and picture. So the main way that we get actionable information in New York City is through the Hub Population Health Network, or the Hub. And the Hub is a tool which allows us to securely exchange aggregate data. This is through what's called a distributed model. It's also called a spoken wheel model. So we write a query. For example, a query might be, EHR system, tell me the number of patients you have who are females, ages 60 to 80, who had diabetes, had an A1C test that was out of control, and don't have another visit scheduled. So these are people who are at very high risk of a diabetic event. And from each practice that we've queried, we'll get a count of the number of patients who meet that criteria. This is good because it protects patient privacy. We don't have a lot of layers of patient privacy concerns, and so we're able to turn around questions very quickly. Now, the hub is a pretty unique and exciting thing because it's not just a querying system within one system. It connects to 700 different independent practices. These practices are all on one EHR vendor called eClinicalWorks, and they are all outpatient practices. There are about 700 practices. Those 700 practices equal about 2 million patients in a given year and 6 million patients since 2009. So there's a huge reach for the hub. And if anybody on here is a little bit more on the kind of technology side, the way this actually works, we have a secured HTTPS connection. We write our queries in SQL. We push them into the vendor server. The vendor server takes them, pushes them to the practice where they are run as a scheduled job each night with anything else that the practice is downloading. So if anybody is using the Microsoft platform, you'll know that every so often, it seems much more often than it used to be, you get a little yellow box that pops up at the bottom of your screen that says you need to restart your computer because security patches have been updated. Our EHR practices are connecting to the mothership of the EHR vendor every night for those security patches, and our queries are downloaded with those. They're executed, and then they're pushed back to the server and scraped into our internal data warehouse. The nice thing is because it's a distributed model, there is never any patient-level data that's shared. This means that we can't do things like an outbreak investigation to contact individual patients. We'd still need to contact a practice and say, do you know who this is? But it means that we have huge flexibility to be very responsive and ask a wide variety of questions. As of this month, we have done 20,800 distinct queries and received over 12 million results. So to give you an idea of who we are capturing here in the hub, we have on the left, the American Community Survey population distribution of New York City for 2013. We have it broken out by both females and males. So this is the survey that estimates the United States population between census years. And you can see on the right is the hub population distribution. And what's notable here is that for women, these two population distributions mirror each other very, very nicely. There are some slight discrepancies, but overall, it is a very, very close representation. And this suggests that we probably have pretty good generalizability to women. What you see in the men is it looks like someone has come and taken a bite out of young men. And this is not surprising. Anybody who has dealt with healthcare data knows that you often see that young men do not go to the doctor at the same rates as older men or young women, and the ones who do might be systematically different. So that's going to be a source of bias that we're going to kind of constantly need to keep an eye on and need to investigate in our data. Another really helpful thing for us is that we do have high penetration in demographic groups that we target. These groups are the groups that are defined by the U.S. Census. They are extremely broad. We do some breakdowns a little bit more by language, but because it is anything that's entered in the EHR is entered based on the feelings of an individual practice, there isn't a fantastic, more granular ethnicity breakdown. So we have to use these census categories. But what you can see is we've essentially oversampled in Hispanics and the Asian population and the other population. And we've undersampled in non-Hispanic whites. Non-Hispanic blacks are about as represented as they are in the overall sample when you compare them to non-Hispanic whites. So these are the groups that in New York City, as the health department, we are often extremely concerned about reaching. These are groups that tend to have worse health outcomes and lower access to health care. So if we have a surveillance system, we want that system to have a really good pulse on these higher risk groups. So looking at the hub, one of the really fantastic things that this kind of data unlocks is the ability to do geographically targeted analysis and for us to know which neighborhoods are doing well and which neighborhoods are doing poorly. And what you can see here is a map of our coverage of New York City in 2013. The district public health offices are the areas that are outlined. Those are areas that have particularly poor health outcomes, and so we as the health health department tend to focus on these areas. And what you can see here is that in our area with the worst coverage, which is Staten Island, it's the island down off the bottom in the left, even in the neighborhood that we do most poorly in, we have at least 4,000 patients. And in our biggest neighborhood, we actually have 118,000 patients. This is remarkable because the local version of the Health and Nutrition Examination Survey, which we have now done twice, which is the only other survey that we've been able to get treatment and control information on it to a complete level in New York City, that survey only has 2,000 people. So we have twice as many people in our smallest neighborhood as compared to the biggest sample size that we've got in that survey. That means that we're going to be able to have a lot of power to see small differences over time and to see small differences between neighborhoods, and that's going to have a big impact for program planning. Also, you can see that about 18% of all New York City came through our doors in 2013, and by our doors, I mean the doors of those 700 practices that make up our network. This means that almost one out of every 5 New Yorkers is coming through our doors, and we feel fairly confident that there's probably some high level of representativeness. So we care about not just all New Yorkers, but especially vulnerable New Yorkers. So I'm going to show you 2 ways to look at this. The first is looking at how well we do at covering hypertensives. So the denominator here is an estimate of hypertensive population that has a personal doctor from a different survey that's done every year in New York City. And the numerator is the number of hypertensive patients who had a visit with a PCIP doctor in 2013. And we broke this out by all practices and then just by our small practices. We do a lot of quality improvement initiatives with our small practices because they are often untouched by other quality improvement initiatives in New York City, and they don't have their own quality improvement staff, yet they deliver a large amount of the primary care in New York City. So what you can see is that in our worst neighborhood, we see about 10% of the hypertensive patients in New York City. In our best neighborhoods, we see 33% and up. Those numbers go down a little bit when you look at small practices, but what you see is really that 10 to 19% or 7 to 19% category encompasses much more of the city. But overall, we're still covering 20% of hypertensives in the city and 15% of hypertensives in the city in those small practices. So we feel fairly good about the reach of any quality improvement activities that we do in terms of their potential impact on population health. Here is a very similar map. This is actually showing the percent of care-seeking diabetics who came through our doors in 2013. You can see that we actually have much better penetration with diabetes than with hypertension. So we have about 20% of all diabetics in New York City going to our small practices, and about 28% of all diabetics in New York City going to any of our practices. And you can see a lot more of that darkest color of 33% and up here on this map, including the South Bronx, Harlem, and East Brooklyn, which are those very high priority, very poor health outcome areas in New York City. What this means is that if we're engaging, as we are, with community partners doing diabetes prevention programs, for example, we have a great reach in the areas that need it most to have a big impact on 1 out of every 3 diabetics in New York City if we really are able to scale that program up. So next we're going to talk a little bit about how we leverage that data for public health, how do we actually move our agenda forwards, and then we'll do some of the result highlights. So after cleaning, what does it look like and what do we monitor? We really focus on the biggest drivers. Oh, yes?
Before we go to our next agenda, can we address one question from our...
Yes, absolutely.
From our participant from the Ministry of Health in Sri Lanka, I believe. How many patient minutes are saved and how many minutes are saved for staff per patient with this system on an average?
So that's a great question. By minutes, I am assuming you mean notes. We talk about it as visits. So I am not a clinician and I am not in the practices, so I can't answer exactly how many minutes are saved. But I can tell you that for those 1.9 million patients that we had in 2013, we had about 6 million patient visits. And I will double check that number when I get back to my desk to make sure I have not led you astray. But so it's our understanding that the practices that do adopt the electronic health record document almost all of their visits in the electronic health record. And when we've looked a lot at data completeness, and what we've generally seen is that especially for really clear standard items such as height, weight, blood pressure, diagnosis, medications, those items tend to be pretty complete. And at a practice, generally it goes by provider. So either the provider enters those things for almost everybody and doesn't really write things down on paper, or the provider really isn't using the system at all. And so sometimes we'll look on the provider level, and 3 providers out of 4 will be using the system and using it well, and the 4th provider basically isn't using it. And we actually have a quality system where we remove people from our estimates who aren't documenting in the electronic health record to try and control for some of that noise. Does that answer the question?
Yes, absolutely. Great statistics. And great explanation. Another question from Win Min from our colleague in Thailand. Can you share one example for quality improvement that you have mentioned?
Absolutely. So right now we have a project that we're calling Dash to the Top. It's an acronym, and I unfortunately do not remember the acronym source, but we looked at these quality measures and we said, so we looked at, for example, all of our practices. What is the percent of patients who has last A1C was greater than 9? So percent of patients who are diabetic and have very poor A1C control. And we looked at our lowest performing practices. So the practices who had the highest percent of patients with diabetes that were really in potential crisis. And we actually put together a team of diabetes experts to work with those practices, and we brought in the support of a part-time panel manager who can call those patients directly and get them connected to diabetes prevention and management programs in the community, who can get them connected to their provider, who can do some of very little bit of the education pieces, but also who can just help the provider send out letters that say, you know what, it's time for you to come in again. I haven't seen you. I'm worried about you, and your last reading was at high risk. A lot of providers aren't used to seeing their data and aren't used to thinking about their care on the population level like this. So they'll know when patient X, when Mrs. Lee is in front of me, her diabetes is not well controlled. But they don't actually think about everybody at the same time, and a lot of times they are shocked by how many of their patients are in trouble, and that you really, if you're going to turn things around, maybe need to take this population view. So that would be one example of one of the diabetes management programs that we're engaged in right now with our lowest performing practices. The other piece is that we actually send people out directly to the practices to help work with them to understand, is this a documentation issue? So for example, is your out of control hypertension that actually you're documenting your blood pressure in the wrong field? Or is this a real issue? And if this is a real issue, what can we brainstorm with you to actually improve the way that we're managing this? Another example is we're working on a positive deviance project. So we're looking at our practices, our whole practice panel, and we're looking at similar practices who do really well and really poorly on hypertension management. So they're in similarly poor areas. They serve a similar mix of minority patients, of Hispanic, African American, generally patients, and they have a similar percent of Medicaid, which is the state-sponsored insurance for more low-income people. And we want to understand what are the factors that are making them successful. So we're actually doing interviews with them, and that's phase one, is just to understand how are practices that don't have any more resources than the practice next door succeeding. And then phase two is to actually develop a quality improvement curriculum around those factors and to try and help some of those lower performing practices adopt some of these higher performing practice criteria that don't require any additional resources. They just require a different way of doing things.
Great. Thank you so much. Very comprehensive. I think we can move on for the next agenda. And
Great.
we'll start the questions later.
So in terms of the areas of data that we handle, we really, again, we really focus on the biggest drivers of morbidity and mortality in New York City, but we are able to access many areas of the record. So we can look at flu vaccine, we can look at preventive services, and you can see here a 2009 example. We looked at the distribution of the percent of patients who were asthmatic and pediatric at each practice that had received the H1N1 flu vaccine. Now that should be 100%. It's not going to be 100%. Let's say a ton of kids had egg allergies. Let's say there were a bunch of objectors, maybe 85%. But what you can see here is that the median is 29%. That is unacceptably low. And we were able to actually give that information to our Bureau of Immunization to reach out and try and improve that. We look at communicable diseases like HIV testing or influenza-like illness. We look at clinical risk factors like body mass index, and that 2010 graph piece is looking at the distribution of BMI. And we look at chronic health conditions like hypertension control and diabetes control. You've heard me talking a lot about that. That's because those are some of the biggest drivers of disease in New York City, with a population that is quickly becoming heavier and sicker. Just to kind of breeze over the kinds of things that we've been able to do, one of the big ways that we are able to take our data and leverage it, in addition to doing quality improvement programs directly ourselves, is to use our data to empower others to further their mission and to inform them about how to use their resources in the best possible way. So this is only internal collaborations. We've worked with our Bureau of HIV to look at whether or not a 2010 testing law improved the rates of HIV testing. We've looked at hepatitis C among baby boomers with our infectious disease folks. We've looked at whether or not substance abuse is being monitored at all in the EHR to understand whether or not a clinical intervention for substance abuse made sense in the primary care setting. We've looked at flu and influenza vaccination and actually made dashboards and sent those out to providers on behalf of the immunization folks in our department. And we've looked at depression screening rates to see whether or not primary care providers are actually targeting depression in the way that they should be, so that the mental health folks could figure out whether they needed to first educate providers or whether they could build an intervention directly with providers because they were already doing the screening. Spoiler, they were not. And then we have lots and lots of exciting things kind of on the horizon. One of my favorite projects that we're engaged in right now is looking at active and latent TB cases in New York City and comparing those to the number of cases that have actually been reported to the health department. It is by law a requirement to report cases of tuberculosis to the health department, but we have found dramatic underreporting, and we have found 10 cases of active TB that we did not know about. And those people with active TB have the potential to start a huge, huge problem in New York City. So this kind of potential of this tool, because it's so flexible, is really deep. And then to kind of breeze through some really my favorite part, the fun pictures of what we've actually gotten out of this system. So what have we done with our data partnerships? Well, we've been able to evaluate citywide policy change. And these are two figures from the paper that we published recently on this HIV testing law evaluation that we did with our HIV Testing Bureau and with the New York State HIV Testing Bureau. And on the left, you can see HIV testing trends by quarter in New York City broken out by age groups. And 18 to 64 and 13 to 17 were ages that were targeted by the HIV testing law, which went into effect in 2010, and you can see that red bar there. And 65 to 100 were the ages that were not targeted. And you can see the age that was not targeted kind of continued at the exact same rate, really didn't make a lot of change. The ages that were targeted improved significantly, and after adjusting for covariates, really did a much more remarkable change, as you'll see on the next slide. On the right, you can see us looking at the boroughs of New York City, which are larger geographic areas that make up the city. And you can see that there are stagnation in some areas, like that Staten Island, that's that little island to the left of the rest of New York City. And the area on the top is the Bronx, and that's an area that New York City Health Department actually targeted with their Bronx Knows campaign. And you can see that it went from 5.3% tested per year in 2010 to 16.4% tested per year in 2012. Now, that's not a dramatic testing rate. We still want to see a lot of improvement, but that is more than, that is about tripled. So we have this huge evaluation potential for things that you need to see at the entire city level that a survey might not capture. And this is actually looking at the changes in the odds ratio. So you can see that there is significant improvement from baseline to year one. Baseline is the year before the testing and law, and year one is the year afterwards. But once you've added in these adjusted factors of location, organization type, patient age, you can see that there were 2 times the odds of testing a patient in year one after the testing law went into effect as compared to the baseline. And this is a really major improvement and something that we feel pretty excited about. We are also able to look at disease surveillance, and we can look at disease surveillance not just in the traditional way that we do of looking at number of cases that come in and get reported to the health department. We can look at whether or not the kind of screening for sort of high yield diseases is happening at the practice level, because we think that that's a really essential piece of surveillance. And if providers aren't screening patients for diseases that we want to know about, we're never going to find those cases. And so what you're looking at here is box plots according to the type of practice site and the rate of the patients that are eligible for a hepatitis C test and whether or not they've actually gotten one. So there's currently an outbreak of hepatitis C among baby boomers, that's older adults born in 1945 to 1965. A lot of them actually had hepatitis transmission back in the 70s when there was a lot more intravenous drug use. Now they may not know that they have hepatitis C, and the effects of hepatitis C in terms of their comorbidities are actually coming out. So we really want this screening push to happen. And what you can see here is it looks like in community health centers, the upper 2 quartiles are really making improvements, whereas the bottom half of community health centers are flatlined, no improvements. So there's improvement, but it's especially among the outliers. Then you can see hospitals, they have not budged. There's no more hepatitis C testing in 2013 than there was in 2010. And you can see small practices are doing a much worse job of hepatitis C testing than community health centers, but there is potentially some improvement among some of those outliers and among the top half of the sample. But there's really, it's really very minor. However, when you look at the proportion of baby boomers who've had a hepatitis C test, which is a different question, you see that there's kind of flatlining in every practice type. And the reason is because the first graph is showing the number of tests they were doing. Well, actually, a lot of practices got better at using their lab interfaces, so you see more and more tests coming online. Here, you're trying to look at the number of patients that have had a test, and that sort of stays the same. So that indicates to us that there's definitely a lot of work that needs to be done with practices to educate them about the hepatitis C outbreak before we're going to find out about those hepatitis C cases. Another example that actually was worked on by Melissa Chu, who is one of the members that's on this call right now and did a fantastic job on this project, and it's slowly coming along, is looking at neighborhood variations and risk factors. So what you are seeing here are maps of the rates of prescription of high-risk medications among older adults. So these are 6 medication classes that are associated with an elevated risk of falling among these older adults. This is ages 65 to 100. And those groups are anticonvulsants, antidepressants, antihypertensives, antipsychotics, benzodiazepines, and sedatives. You can see that antihypertensives are almost universal. All but a few boroughs have 70% or more of their patients, older adults, on an antihypertensive medication. But all of the other pieces, it's 20% or less. But what's really interesting here is that you can see different neighborhoods lighting up for different conditions. So although there are a couple neighborhoods, like the South Bronx, which is on the bottom of the kind of first puzzle piece, that light up in multiple maps, there really is no kind of continuity across every piece. This suggests to us that it's not necessarily that there's just a couple problem providers. There are providers across the spectrum that are engaging in this prescription practices, and if we want to educate providers about the fact that some of these prescriptions come with a really elevated falls risk and they have to be prescribed very carefully, we're going to need to do it at the citywide level, potentially with a citywide communication campaign, rather than a detailing campaign, for example, where we pick a targeted number of practices and visit them and talk to them about changing their habits. So this is really useful for program planning. It's also very useful as an exercise in seeing how you can see risk mapped throughout a city at the neighborhood level using this data, because we have such large sample sizes for each neighborhood, even among an older adult group, for example, so the 65 to 100. Another thing that we can do is actually build robust surveillance systems, and that's just what we're doing right now. We're building something called the New York City Microscope. This is a surveillance system built entirely on data from primary care electronic health records. We want it to be as similar as possible to the general doctor-going population, so we are not allowing in specialists so that our prevalences are not dragged upwards, for example, with too many cardiologists. We are real focused on chronic disease, and we're validating that system against a gold standard survey, which is the New York City Health and Nutrition Examination Survey of 2013, and a telephone survey, which is the Community Health Survey of 2013. We're doing it at both the population and the individual levels, and here is just the results of some very preliminary comparisons. And you can see the New York City Microscope, which is the electronic health record data. We have 640,000 patients. Those are all adults who went to primary care providers. And you can see that the obesity estimate does not look like the Community Health Survey or the New York City HANES. It's a little bit higher, but it is ballpark pretty similar to the New York City HANES. CHS, the Community Health Survey, is self-reported, so we would expect it to be much lower, and it accordingly is. Hypertension diagnosis is extremely similar across all three sources. Hypertension treatment is much higher in the New York City Microscope, and we're still trying to understand why that might be, but that's really important to know when we're trying to extrapolate information we have to the general population and understand what this might say about population treatment of hypertension. So the Microscope sample size, we query, just to give you an idea of how the mechanics work, 660 practices, 2,229 providers. That gives us 1.3 million adults seen in 2013. We then chuck all the specialists, and we're left with 766,000 patients. And then we do quality inclusion criteria, so we make sure that all of those providers are good at documenting. We're left with 715,000 adults. This is for 2013 versus 2012, which is the data you saw on the last slide. And that translates to about 393 practices and 953 providers. When you look at that against the doctor-going estimates of New York City population, you can see that we cover about 12% of the annual adults and 17% of adult primary care goers. So even though this is a much more rigorous, smaller sample than the entire hub, we still have pretty good penetration. Next, if anybody's interested, we're going to be producing a full report of our findings to identify the areas of indicators that perform the very best and indicators that might be very amenable to being tracked in electronic health records in December, and I'm happy to share that with anybody who's interested. We are now doing a chart review of the New York City HANES participants that also were connected to an electronic health record, and next on the dossier will be trends and neighborhood level validation. We also build tools for our community partners. So this is an example of a website that we built called Healthcare in My Neighborhood, and you can navigate around to different maps and see the percent of providers in that neighborhood who are doing A1C testing, A1C control, et cetera, et cetera. You can look at diabetes, at high blood pressure, or preventive screening. And then you can also click on an individual neighborhood and get a community health profile for the whole neighborhood. And this is really helpful because community-based organizations don't have the ability to very quickly pull data into a grant on their very own neighborhood, and this gives them all things in one place. To wrap it up, data that we have allows us to do projections for real-time surveillance and program planning, and this is an example of a dashboard that we use right now. These are weekly queries that we're doing every week, and this is a dashboard that is circulated to all of our quality improvement specialists so that when they go out in the field, they know what they're dealing with. They see practices that have the highest issues with hypertension, practices that are having the problem with control, where are most hypertensives and diabetics coming in, both at the practice level and in the neighborhood level, et cetera, so that they can target their work in the best possible way. And the last piece is we make sure that we give back. And so what you're seeing here is one of the dashboards that we actually give to our providers that shows the threshold of quality that we hope that they will achieve, and then the 6-month average of how well they've been doing compared to that threshold. Where applicable, we also put on the citywide average to show how well their peers are doing and use that amazing piece of competitive nature of doctors. So we think that these taken together have the ability to really dramatically impact the way that we do public health practice. And that's it. I'd be happy to take your questions.
Thanks, Ramla, for that very good presentation. There's a question here from Malaysia, from the Clinical Research Center of Malaysia. May I know how is the project being funded? And from the software, the hardware maintenance at the provider side, and then at the New York City DOH and the analytics, do providers have to pay annual fee to subscribe to the system, or is the funding coming from DOH?
That is a great question. So the providers themselves have adopted this system. In the beginning, we help them, we help providers who serve very low-income patients with a stipend to help defray some of the costs of adopting the electronic health record. But at this point, all of our providers are paying their own subscription fees for the software. In the United States, reimbursement is being changed so that they will not get reimbursed by the federal government, which is a large percentage of care, if they do not have an electronic health record. So most providers are now motivated to adopt the electronic health record. They're willing to share data with us at no cost because we offer them a lot of services. So they sign on with us and they agree to actually give us a portion of the money that they will be getting from the federal government for adopting the electronic health record because we are going to help them with that adoption process. So we've created a kind of business use case. On top of that, there are a lot of grants that we've gotten to look at individual research projects, and we use some of that grants. We write in overhead for running the system, and then some people are actually funded by the city. So there's really a kind of blended funding stream that keeps this going, if that answers the question.
Right. Another question from Malaysia again. From the 700 clinics using the EHR, what is the proportion over the total number of clinics in New York City?
Ooh, so that is a great question. So there's actually, the 700 clinics are just the clinics that we have connected up to this special data system. There are about 15,000 providers that we know are participating in our network right now. There are about 40,000 total providers in New York City. We think that there are a lot of providers that are seeing very high-income clients that are not connected to us. So we don't know what percentage of practices in New York City are using electronic health records. We think it's lower than the nationwide average. So our guess is probably about 70%, because now the nationwide average actually in 2013 has risen to about 75%, but we don't entirely know.
All right, thanks. Any other questions or responses from our chat box? You may now send it to us so that we can maximize the presence of our speaker this morning. All right, so you said it's about 70%, or as a little bit lower to the average that you have.
Yeah,
Right?
so I think about 70% of providers, yeah.
All right. Okay. So I have a personal question regarding the implementation of the project. However, aside from the law which states that all healthcare facilities should have EHR to be able to reimburse, what is the main encouragement of people who uses the system right now?
So the system being the hub network?
Yes.
So that is a fantastic question, and people all over the country are trying to understand the best ways to engage. I think the way that we've really gotten provider engagement is that we make sure that we give back. So this dashboard, we've actually been giving out a form of dashboards since 2011 or so, maybe even 2010. And we think that this is hugely transformative. So providers often have never been able to see their data. They see one patient at a time. They don't ever see it in aggregate for a lot of providers. So we think helping on the analytics side means that we'll get buy-in. We've also developed a trust, and I think somebody said there's no commodity that's more expensive than trust, and I think that that is extremely true. And so we have shown over the course of years that we are willing to go to bat for them in terms of national legislation. We're testifying for them whenever their interests come up. We are providing programs that directly help them. We are trying to only bug them with information that's helpful. We focus a lot on billing services, not because we care, but because we know that if they do not get paid for smoking cessation counseling, they won't do smoking cessation counseling. So we try and really help them use this tool to maximize their billing so that they can actually get reimbursed for the care that they're doing. And because we've really built up this trust and this value, we are able to really take advantage of it.
All right, thanks. There's more chat here in our box from Melissa Chu. She wants to add something. Melissa, do you have a mic with you so that you can deliver this to our attendees this morning? Hi, Melissa.
Hi, Aliyah.
You can have the floor and give us your thoughts.
Okay. Can you hear me?
Very well.
Great. So my question here is like, it's just oh, no video, please. Thank you.
Right.
So it's something that I've been thinking with about ever since I got back here. You know, what does this mean for Asian countries here? We have more autonomy in terms of deciding on which EHRs we use. So I know, for example, in MLH Malaysia, teleprimary care, or TPC, is used across multiple states in the country. And I'm sure in other countries, Ministry of Health-related facilities use the same EHR. So, you know, the potential impact of turning EHR into a population health monitoring tool is tremendous, and that's food for thought.
Right. And also here in Asia, where many countries are still starting their systems and slowly implementing them in the ground. What is your maybe encouragement, Remle, to those countries who are still are just starting their hubs, and they're starting their electronic health records to be able to reach this kind of success in the PCIP?
Sure. I mean, I think we're just starting in a lot of ways. So when I joined the Primary Care Information Project in 2007, the EHR adoption in New York City was extremely low. I think it was probably about 30%, if even. So I think that we have been doing a lot of this, and I think a couple things. I think knowing that there's going to be mistakes, and as much as possible, learning from the mistakes of others and other countries and other systems to do things in a way that makes sense the first time so you don't have to change the system afterwards, which is extremely disruptive. I think making sure that public health and population health and healthcare reimbursement has a seat at the table during the conversation about what kind of system are we going to adopt, how are we going to roll it out, how are we going to train providers, is really important. So for example, you could roll out a tool where providers have essentially just put into electronic format everything they were doing on paper. And I've seen some electronic health records here in the States that do this, and they can just free text in everything. Well, that means you're not going to be able to do any queries on blood pressure, or it's going to be extremely difficult to do so. And so you want a query that allows your health system, your healthcare providers, eventually your patients, and your health Ministry of Health to all be able to get utility from the data. And I think that there is a case to be made in whoever happens to be the payer in your particular situation, that it's in the payer's best interest to have a data system that's really robust so that the payer can identify places where real savings can come up. So I think that it's really important to think really carefully at the beginning. I also have several questions in the My Q&A box. I'm not sure if everybody else can see those, about who initiates the Quality Improvement Initiative and error conditions that have been reported from queries. Can I go ahead on those two?
Yeah, go ahead.
Great. So Quality Improvement Initiative generally gets talked about by the leadership. We work in a really kind of flat area, so lots and lots of folks might have ideas, and we really solicit those ideas. But the Commissioner of Health will say, I want our big focus now to be diabetes, for example, and so we'll really focus on diabetes. She has said she wants her focus to be on underserved presentations, and she wants to and that's underserved populations, excuse me, and she wants that to be our focus. We do sometimes get errors reported from the queries. Either we're querying in the wrong place or we have an issue, but we have technicians who've been very good at being able to fix those, if I'm answering that correctly. For ILI, there's another question. For ILI patients, are there any tests carried out to make sure that the patients are confirmed influenza and their types? Can you tell me or show me the average of ILI data collected and how they are transformed to policy? So that's a fantastic question. ILI is actually done a little bit outside of my area, but the person who sits across from me does ILI. So we are actually engaged in a CDC initiative where we do a sentinel sample of our outpatient practices, and we look at their ILI rates every week, and then we send out flu testing kits to a subsample of those practices and a subsample of their patients to do confirmation and typing of the influenza. So we do syndromic surveillance that is collecting the signals, both from inpatient and outpatient data, and then we do that follow-up to make sure that what we're collecting and what we're sniffing is real. And that information is shared both with our Bureau of Infectious Disease and also with our CDC colleagues, Centers for Disease Control colleagues at the federal level, to make sure that that information is used in a timely way to understand flu trends across the whole country. So that, I guess that would be how they're transformed to policy. So we communicate those to our Bureau of Communicable Diseases and our influenza vaccine folks, and they then say, okay, to the New York Times, we're going to do a press release that says, this is the peak week for flu, protect yourself. Or that we think the peak week for flu is going to be in December, so this is one of the last weeks where you're going to be able to get immunized, so please do a big immunization push. And they find it, a way to make it sexy and exciting. But and then the CDC gets it, and the CDC is able to identify at the nationwide level who should be getting batches of flu vaccine. Are they on track? Are they hitting their targets? Is this the right type of flu, et cetera, et cetera? So I think it sort of filters into the policy level.
Right. And I see that the results are really being spread across the area. So I think they find the reports very useful to their setup. Last question from I think this is from Myanmar. Is the system you're using open source application, and how do you maintain data security about HIV and substance abusers?
great questions. The system is not open source. This is a proprietary querying system that we built inside the eClinicalWorks product. We are actually also engaged in a project called Query Health, which is run out of the Office of the National Coordinator on Health IT for the United States, part of the federal government, to create more open standards that would allow data exchange across multiple platforms, not just one EHR vendor. So that's sort of our solution to trying to expand this. And in terms of data security, we never get identifiable data. So we might find out that there are 2 HIV patients, but we are lucky enough that New York City has really large populations. So even when we find out that there are 2 HIV patients, we never get into small enough sub-cell sizes. The denominator for that cell is so large that there is no re-identifiability. So we don't, we would never query on, we can't query on name, we can't query on address, we can query on zip code, but every zip code in New York City except for 2 has more than 20,000 patients, and we actually only query on zip codes when they've been combined already. So we don't query on anything that has less than 50,000 or more patients or so as a denominator, so we don't have any way to trace something back to the individual.
All right. Thank you so much, Remba Newton-Dame, for that very comprehensive presentation, very useful for our region and also those who are planning to implement such a same system to their countries. Thank you also to the attendees that we have this morning from the Ministry of Health of Malaysia, from the Indonesia, from the Philippines, from Vietnam, from Thailand, and from Myanmar and Nepal. And I hope I have covered all the countries who are inside this meeting room. See you next for the next session of our AHIN Hour on March 26th. That will be 16-hour UTC GMT +8 or 4 p.m. Manila time. Thanks also to Melissa Chu, who sponsored or primarily organized for this AHIN. Thank you so much and see you next meeting. Thanks, Remla.
Thank you.